Imagine a massive library trying to catalog all human suffering. For centuries, psychiatry kind of tried to force every story, every unique experience from every community on Earth into just a handful of, well, standardized universal boxes.
But what happens when people's experiences just don't fit neatly into those boxes? We know now, I think quite clearly, that culture isn't just some kind of varnish on mental illness. It fundamentally shapes how suffering is expressed, what it actually means to people, and how they go about seeking help.
And that's exactly our mission in this deep dive. We're drawing entirely from the chapter Cultural Concepts of Distress and Assessment in Kaplan and Sadock's comprehensive textbook. We want to extract those critical frameworks used in modern cultural psychiatry.
Yeah, the idea is that if you're working with diverse patients, these concepts are really key. They're sort of a shortcut to providing more accurate, informed, and sensitive care.
Definitely. And we need to start, I guess, by clearing away some old baggage, some outdated terminology that actually causes more harm than good.
Right. We have to talk about the term culture-bound syndromes.
Okay, so let's unpack that. Why was that phrasing so problematic? What was the issue there?
Well, it carried this really unfortunate implication, didn't it? It kind of suggested that only non-Western forms of distress, things people might have heard of like Lata or Koro, were somehow uniquely bound by their local culture.
Right, as if Western categories like major depression or anxiety disorder were somehow pure science, universal.
Exactly. It really exoticized the other, often exaggerated differences, or assumed these conditions were completely stuck in one geographic place. It created this kind of hierarchy.
My illness is the real global one. Yours is just some local quirk.
Precisely. And often it wasn't even historically accurate. The chapter gives a great example, brain fag. It became known as this syndrome among students in Nigeria, involving mental fatigue, trouble concentrating.
It sounds quite specific.
It did, yeah. It felt distinctively Nigerian. But historical research actually shows very similar complaints, even using the term brain fag, were common back in 19th century England.
No kidding. So it wasn't bound at all.
Not really. It likely traveled, maybe imported it as part of the whole colonial system. It shows how these things move.
Okay, so if we're ditching that term, what does the DSM-5-TR use now? What are the more refined concepts under this umbrella of cultural concepts of distress or CCDs?
Right. The DSM-5-TR framework tries to capture the complexity better. Think of it as layers. First, you have cultural syndromes. Now, these are clusters of symptoms that tend to occur together, often in a predictable context or following a certain course.
Okay, so like patterns we recognize.
Exactly. We think of depression as a syndrome, for instance. But local culture influences how it's recognized, maybe what symptoms are emphasized, and even its outcome. The key difference now is acknowledging these patterns aren't necessarily geographically isolated. They travel with people.
Got it. So pattern recognition, but without the bound assumption. What's the next layer?
Next are idioms of distress. These are crucial. They're the ways people talk about suffering, the language they use, or even nonverbal expressions. Importantly, using an idiom doesn't automatically mean someone has a psychiatric disorder.
Can you give an example?
Sure. Someone in a Latin American context might talk about having nervios nerves, or elsewhere someone might say they're thinking too much. These are idioms. The clinician's job is to figure out, okay, is this idiom signaling general worry, everyday stress, or does it point towards an underlying condition like anxiety or depression?
So the language itself is a really important clue, even if it's not a diagnosis in itself.
Absolutely. It's how people frame their suffering, which leads to the third layer, causal explanations or attributions. These are the local beliefs, the systems of knowledge people use to explain why they're experiencing this distress, what caused it.
And you said earlier this really influences help seeking.
Hugely. It's arguably the most critical part for treatment planning. Think about Haiti, for example. People might distinguish between maladie diable illnesses, seen as caused by malevolent forces, maybe requiring a spiritual healer, versus maladie bon Dieu's illnesses, seen as part of the natural order, maybe sent by God, which might lead them to a medical doctor.
Ah, okay. So the perceived cause dictates the pathway to care. Makes sense.
And then all these elements, the syndromes, the idioms, the explanations, can sometimes be part of broader, culturally recognized categories, often called folk illness categories. Like nervios could refer to the specific syndrome attaque de nervios, or just the general idiom of feeling nervous, or even the explanation itself.
Okay, that maps it out conceptually. But how does this relate to standard psychiatric diagnosis, like the DSM? You mentioned a tricky word earlier, orthogonal.
Yes, orthogonal. It basically means these systems, The cultural concepts and the formal psychiatric diagnoses are like different axes on a graph. They're alternate ways of classifying distress, running in parallel, but not directly mapping onto each other easily.
So not a simple translation guide then.
Definitely not. You rarely get that neat one-to-one match. A single CCD, let's take Nervios again, might overlap with symptoms found in major depression, panic disorder, and somatic symptom disorder in the DSM. That's one to many.
Or the other way around.
Exactly. You could have major depressive disorder presenting in ways that local communities might label with 5 completely different cultural terms or idioms. That's many to one. So just relying on a symptom checklist based on the DSM, well, it can completely miss the mark in understanding the patient's experience.
Right. That highlights why this is so essential. Okay, we have the framework. Let's make it concrete. Can we dive into some specific examples? Maybe start with one that's been well studied.
Let's do it. A classic example is ataque nervios, the attack of nerves. It's primarily described in Latino-Caribbean contexts, Puerto Rico, Cuba, the Dominican Republic especially.
Okay, so paint a picture for us. If we were observing an attack, what's the core experience? What does it feel like for the person?
It's typically an acute, very intense emotional storm. And almost always it's triggered by a sudden, severe interpersonal stressor, usually involving a close family member or relationship conflict. The absolute defining feature is this overwhelming sense of loss of control.
And what does that loss of control look like? How does it manifest?
It's usually quite dramatic. Physically, the person might experience trembling, a feeling of heat or pressure in the chest, heart palpitations. Behaviorally, you see intense emotional expressions, shouting, crying, maybe swearing. And then these action dimensions, they might strike out, hit things, fall to the ground, or shake with movements that can look almost convulsive.
Wow, that sounds incredibly intense.
It is. But interestingly, the attack often stops quite quickly. And this is often helped by culturally specific responses from others, people offering support, maybe rubbing alcoholato, a type of rubbing alcohol, on the person's forehead, and crucially, allowing the person to desahogarse, to vent, to tell their story, to unburden themselves. That often brings relief.
You mentioned earlier that the risk associated with this is significant. The prevalence seems high, almost 14% lifetime in Puerto Rico, according to the source material. And it looks like a panic attack, but often isn't.
Right, there's overlap, but only about 36% of these episodes actually meet the full DSM criteria for a panic attack. Things like the slower buildup sometimes, and that very specific interpersonal trigger often differentiate it.
But the really alarming statistic is the link to suicidality.
That's the critical clinical point. The research cited shows a really strong association between experiencing attacks and having suicidal thoughts. The odds ratio was 6.2. And even more concerning, with suicide attempts, an odds ratio of 8.1. And that's even after controlling for other psychiatric diagnoses.
An odds ratio of 8.1. That's staggering. That statistic alone tells you why understanding this cultural context isn't optional. It's a matter of safety.
Absolutely. It means assessment has to prioritize safety, support, and understanding that trigger. Treatment then needs to focus not just on, say, anxiety symptoms in isolation, but on the underlying psychopathology and those triggering interpersonal dynamics.
Okay, a very powerful example. Let's transition to our second case, possession syndrome.
Right. This refers to these involuntary trance states where someone experiences a profound shift in their identity, feeling as though they've been taken over by an external agent. It's found globally in many different cultures.
And how does the DSM handle this?
In the DSM-5-TR, it's often categorized under dissociative identity disorder, or D, specifically as the possession form variant. It's worth noting the ICD-11, the international classification, actually lists it as a distinct disorder.
So what's the key difference between this possession form and the more commonly discussed non-possession form of D?
In the non-possession form of deity, the alternate identities or alters are typically experienced as internal, like different parts of the self. In the possession form, however, the identities that emerge, which might be perceived as spirits, deities, ancestors, or other entities, are experienced as external agents taking control.
So the source feels outside the person.
Exactly. And crucially, these episodes are involuntary, they cause distress or impairment, and they're not part of accepted cultural or religious practices like some forms of voluntary trance.
What tends to trigger these episodes?
They often seem to arise in the context of ongoing subacute stress or conflict, frequently social or family-related conflicts. And there's research, particularly from places like South Asia, suggesting a possible link to undisclosed early trauma, especially experiences of violence against women in patriarchal settings where direct expression of distress might be difficult or dangerous.
That adds another layer of complexity to understanding the distress. Okay, let's look at our third example, one with a really interesting history, Shenjing Shuaru.
Yes, Shenjing Shuaro, which translates roughly as weakness of the nervous system. This concept emerged in China in the early 20th century as an adaptation of the Western diagnosis neurasthenia.
Neurasthenia, meaning lack of nerve strength, basically.
Exactly. And for a long time, Shenjing Shuaro was actually the most common diagnosis for neurosis in China. Unlike the sudden onset of an attack, this typically develops gradually. It's often linked to ongoing, frustrating, or worrying social situations, problems at work, family conflicts, academic pressures.
So what are the main symptoms? What would a clinician likely hear about?
Common complaints include things like persistent insomnia, headaches, dizziness, feeling mentally and physically fatigued, difficulty concentrating, and there's often a specific emotional component called fan now.
Fan now, how would you describe that?
It's sort of a complex mix, like being deeply troubled, vexed, irritable, but also worried, often about unfulfilled desires or ambitions not being met, kind of agitated worry.
Now, you mentioned a specific cultural mechanism here relating to how symptoms are interpreted. Can you explain that?
Yes, this is really key. Many patients experiencing Shenjing Shuairu tend to use what's called a somatopsychic interpretation. They see the external stressors, the work problems, the family issues, as directly impacting their physical body first.
So the physical symptoms come first in their explanation.
In their explanation, yes. The headache, the fatigue, the dizziness, those are primary. The psychological distress, the fan now, is seen as secondary, a consequence of the physical disturbance. This way of thinking is often rooted in traditional Chinese concepts about the flow of kunit, vital energy, and the functioning of the nervous system, Shenjing.
And why is framing it that way so important for the patient?
It serves a really important function in avoiding stigma. Explicit mental illness labels can carry heavy social stigma in many contexts. By framing the problem as primarily physical, a weakness of the nervous system caused by external stress, patients can seek help, often from general practitioners or neurologists, without having to adopt a potentially stigmatizing psychiatric label.
So it's a culturally acceptable pathway to care for distress that might otherwise overlap significantly with DSM categories like depression or anxiety.
Exactly. Studies have found high rates of conditions like major depressive disorder co-occurring in individuals diagnosed with Shenjing Shuairu. The cultural concept provides the entryway to seeking help.
Okay, these three examples really illustrate the complexity, the unique phenomenology, the overlap, the cultural meanings. So given all this, how does a clinician actually do this? How do they systematically bring this cultural understanding into their assessment?
That's where the Cultural Formulation Interview, the CFI, comes in. It was developed for the DSM-5 to operationalize the principles laid out in the outline for cultural formulation, OCF. It provides a structured way to have this conversation.
So it's a practical tool, not just a theoretical idea.
Right. It ensures this exploration happens systematically, rather than being an afterthought or depending solely on the clinician's intuition.
Before we look at the CFI structure, let's quickly touch on how culture itself is defined in the DSM-5 TR, because it's quite broad, isn't it?
It is very broad. It's not just about ethnicity or nationality. The DSM defines culture as encompassing the values, beliefs, knowledge, practices, essentially the systems of meaning shared by any social group. This includes groups defined by age, gender identity, sexual orientation, occupation, religion, socioeconomic status.
And
crucially, it also includes the culture of the clinician and the healthcare setting itself. The CFI is designed to be potentially useful for every patient, because everyone has cultural influences shaping their experience and expression of distress.
Okay, so the CFI itself, it's built around 16 core questions, grouped into 4 main areas. Can you walk us through those domains?
Sure. The first domain is the cultural definition of the problem. This starts by asking the patient directly, using open-ended questions like, "What brings you here today?" or "What troubles you most about this problem?" The goal is to elicit their perspective, using their own word, their idioms of distress.
Getting their story first. What's the second domain?
The second is cultural perceptions of cause, context, and support. Here you ask questions like, "Why do you think this is happening to you?" exploring their causal explanations. It also probes stressors, available supports, family, community, and critically asks about the most important aspects of the patient's identity, how they see themselves. This helps avoid clinician stereotyping.
Makes sense. Domain 3.
Domain 3 looks at cultural factors affecting self-coping and past help-seeking. So what has the patient already done to cope? This includes asking about home remedies, advice from family or friends, or use of traditional, religious, or alternative healers. It also explores what helped or didn't help, and any barriers they faced in seeking care before.
Understanding their journey so far. And the final domain.
The fourth domain is cultural factors affecting current help seeking. This focuses on the present encounter. What are the patient's preferences and expectations for this treatment? What kind of help are they hoping for? And very importantly, it includes direct questions about the clinician-patient relationship.
Ah, that sounds potentially awkward, but also really important. What kind of questions?
It allows the clinician to ask explicitly if the patient has any concerns about the interaction due to differences in background, potential misunderstandings, experiences of racism or discrimination within healthcare, or power dynamics. It opens the door proactively.
That seems incredibly valuable for building trust and rapport right from the start.
Absolutely. It shows respect and acknowledges potential barriers head-on.
And the information gathered through the CFI isn't just, interesting background. It directly shapes treatment, right? You mentioned an example earlier, the friendship bench study.
Yes,
Yeah.
a fantastic example from Zimbabwe.
Mm.
The primary local idiom of distress there was kufungisa, which literally means thinking too much. So the psychological therapy developed wasn't framed as treatment for depression.
How is it framed?
It was framed as helping people manage kufungisa. They used local concepts, like talking about kavua opening the mind, through problem-solving talk therapy delivered by trained community health workers, the grandmothers on the benches.
So by using the local idiom, the local framework.
The intervention became much less stigmatizing, much more acceptable to the community, and ultimately significantly more effective in reducing symptoms than standard care. It met people where they were using their language.
That really drives the point home. So to synthesize all this, integrating these cultural concepts of distress, using systematic tools like the CFI, it pushes clinical care beyond just symptom lists.
Exactly. It forces us as clinicians to engage with the meaning of the suffering for the patient and the real-world social consequences of their distress within their specific community, their local world.
And doing that work, that rigorous engagement, it builds better rapport, helps prevent misdiagnosis, and ultimately leads to better outcomes because the treatment actually resonates with the patient's reality.
Precisely.
Stepping back, the study of these cultural concepts offers something else too. It serves as a really valuable critique of our own Western classification systems. It reminds us that all nosologies, even the DSM, are inherently cultural products, shaped by specific historical and societal contexts.
That's a profound point. It encourages a certain humility about our own frameworks.
So the final provocative thought for our listeners as they reflect on this deep dive into distress is maybe centered on that question.
What is truly at stake for this individual patient sitting in front of me within their specific local world?
A question well worth keeping in mind. Thank you for joining us on this deep dive into cultural concepts of distress and assessment.